Hello, my name is Dr. Julio Novoa. I'm a practicing cosmetic OBGYN from El Paso, Texas. Today's lecture, titled Avoid the C-Section, will discuss the facts about the vaginal birth after cesarean section, also known as the VBAC. Introduction. The purpose of this lecture is to provide educational information for patients interested in attempting a trial of labor after cesarean, also known as TOLAC, or the vaginal birth after cesarean section, commonly known as VBAC. Although the nationally and internationally recognized guidelines regarding VBAC are very similar, a majority of patients requesting a VBAC have been misinformed as to the risk versus the benefits of attempting a vaginal delivery after cesarean section. For women considering having a VBAC, the following point of fact should be known. VBAC is not considered to be dangerous and should be encouraged for the vast majority of women with a previous cesarean section. The current nationally recognized guidelines regarding the VBAC clearly state that women with one or two previous low transverse cesarean incisions, women carrying twins, and women with an unknown type of uterine scar are considered appropriate candidates for either a TOLAC or a VBAC. What is a TOLAC versus a VBAC? The trial of labor after cesarean, also known as TOLAC, is defined when a patient attempts a vaginal delivery while in labor or the trial of labor after having undergone a cesarean section with a previous delivery. The vaginal birth after cesarean, or VBAC, is defined when a patient has delivered vaginally after attempting a trial of labor after a previous cesarean section. Therefore, a VBAC is a successful TOLAC. The history of the VBAC. Prior to the 1970s, the rate of cesarean section in the United States was less than 5%. However, due to advancing technologies such as the external fetal monitoring, as well as incredible legal pressures causing doctors to practice defensive medicine, the rate of cesarean section is now approximately 33%. However, despite the high rate of cesarean sections, studies have failed to demonstrate any significant improvement in the care of either the patient or her baby. On the contrary, there is a significant body of evidence showing that the current rate of cesarean section actually puts the patient and her baby at risk. So exactly what happened? In order to understand the history of the VBAC, it's important to go back to 1916, where Dr. Edwin Cragin coined the term once a cesarean, always a cesarean, meaning that once a woman had undergone a cesarean section, she should always undergo a repeat cesarean section. However, Cragen's comments were based on a specific medical scenario representing only 1 to 2% of laboring women. And this was during a period of time before fetal monitoring was available, and when rickets and pelvic deformities were very common, when medication for augmentation of labor such as Pitocin was not available, and when the cesarean section was crude and dangerous, and also before antibiotics were even created. Despite this, obstetricians adopted Cragen's opinion and made it dogma and practice doctrine regarding all patients for over 50 years until in the 1960s when studies began to show that patients who accidentally labored long enough to deliver spontaneously were found to deliver without serious risks of complications. Unfortunately, despite over 40 years of data supporting the benefits of the VBAC, obstetricians continue to misquote Cragen, failing to understand that Cragen coined the term when he was describing a very small percentage of women who had attempted a vaginal delivery and were unsuccessful, and based on his observations and the events of the previous delivery, was recommending that these women undergo a repeat cesarean section. In a nutshell, we as obstetricians who generalize Cragen's comment, once a cesarean, always a cesarean, got it wrong and have been slow to admit and even slower to correct our mistake. Despite Cragen's rule about cesarean section, beginning in the 1960s, a mother-driven movement supporting VBAC served as a catalyst for almost 30 years of increasing numbers of VBACs in the United States. So much so that in 1996, the VBAC rate in the United States was an impressive 30%. Unfortunately, in 1996, a highly publicized study in the New England Journal of Medicine led ACOG to recommend highly restrictive and poorly based guidelines regarding the VBAC, which caused a significant drop in the number of VBACs in the United States to less than 10% today. So what is ACOG? ACOG is the American Congress, formerly College of Obstetricians and Gynecologists. It is the largest society of OBGYN doctors in the United States, with approximately 55,000 members. Its fellows are required to be board certified, most often by the American Board of Obstetrics and Gynecology, or ABOG. And over 90% of practicing board certified OBs in the United States are members of this organization. Based on the 1996 ACOG guidelines, obstetricians began to tell their patients that the VBAC was dangerous and should not be attempted. Further, hospitals began to make it exceedingly difficult for obstetricians to perform these procedures in their hospitals. Despite the lack of any supporting double-blind studies, ACOG incorporated in its 1996 guidelines what is commonly referred to as the immediately available rule. This rule requires that the OB or obstetrician be immediately available in-house or in the hospital during the entire labor of their patient. In other words, if a patient is found to be in labor and she labors between 12 and 36 hours, that patient's OB is required to be on labor and delivery, or at least in the hospital during the entire 12 to 36 hour period of time. This makes it exceedingly difficult or virtually impossible for the majority of OBs to assist with a VBAC attempt. Luckily, in 2010, based on recommendations from the U.S. Department of Health and Human Services, the ACOG changed some of its recommendations regarding the VBAC. In its July 2010 bulletin, the ACOG stated the following, quote, "Attempting a vaginal birth after cesarean, VBAC, is a safe and appropriate choice for most women who have had a prior cesarean delivery, including for some women who have had 2 previous cesareans," unquote. Also in July 2010, Dr. Jeffrey Eckert the past vice chair of the Committee on Practice Bulletins for the ACOG, stated the following, quote, "The college guidelines now clearly say that women with 2 previous low transverse cesarean incisions, women carrying twins, and women with an unknown type of uterine scar are considered appropriate candidates for a TOLAC," unquote. ACOG's effects. Although unintended, the 1996 guidelines were the single biggest reason why the number of VBAC deliveries plummeted to its current levels, from as high as 30% in 1996 to as low as 1% in some regions of the United States. Although ACOG revised its guidelines in 2010 and appeared to be encouraging, these changes are, frankly, too little, too late, and have failed to correct the damage caused by the 1996 ACOG guidelines. Why aren't more obstetricians doing VBACs? Despite there being an overwhelming amount of data showing that VBACs are generally safe, the vast majority of obstetricians still do not offer this service. And why is this? It's because there is no incentive to change this policy on the part of the OBGYN. Because of the 1996 ACOG restrictions, the VBAC requires an intensive level of dedication on the part of the obstetrician. In the majority of cases, OBs willing to assist their patients with a VBAC must follow the immediately available rule, which means that they have to be present during the entire active labor of their patient. Therefore, VBACs are not cost-effective for the OB. Consider the following. Most OBs can do a repeat cesarean section in less than 30 minutes. VBACs, however, take between 4 and 36 hours to complete. Based on a comparison of time and effort, an OB is paid significantly more money for a cesarean section as compared to a VBAC. As a consumer and patient, what do you believe would be the expected outcome if an OB is paid the same amount of money for a 30-minute cesarean section as compared to a 36-hour VBAC? This may explain why the number of VBACs has significantly dropped over the past 15 years. VBACs and VBAC with previous cesarean section times 2 are relatively safe and pose little risk to either mother or baby. When a VBAC is attempted, it usually leads to a vaginal delivery in between 60 and 90% of cases. The uterine rupture, quoted by most to be the most serious and dangerous complication related to a VBAC attempt, and considered to be the biggest risk regarding a TOLAC or VBAC, occurs in less than 50 out of every 10,000 VBAC attempts. If a uterine rupture does occur, the risk of death to the mother is almost 0%, while the risk to the baby can be as high as 6%. VBACs are not being offered more often because of the personal decisions on the part of the OB rather than based on risks to the mother or baby. Contrary to popular opinion, neither the American Board of Obstetrics and Gynecology nor the American Congress of Obstetricians and Gynecologists have any enforcement power regarding the ACOG guidelines, which means that obstetricians do not have to follow the guidelines when taking care of their patients. However, it is both unprofessional and unethical for an obstetrician to improperly inform or refuse to discuss with their patients the current national recommendations regarding VBAC. Therefore, a patient has a right to be properly informed regarding her VBAC options, and if improperly informed, she has a right to speak or send a complaint to the governing medical board for her particular state. A patient cannot be forced to repeat a cesarean section simply because their doctor refuses to perform a VBAC. Also, a patient cannot be forced to repeat a cesarean section simply because their hospital has administrative policies against a VBAC. Recommendations. A patient should discuss having a VBAC with a previous cesarean section times 1 or times 2 with their obstetrician at their first appointment, and should get a VBAC delivery plan from their OB in writing if considering a VBAC. A patient should understand that at the current time, VBAC attempts with previous cesarean sections times 3 or higher are not recommended and should not be attempted. As a patient, you should request documentation from your OB regarding the number of VBACs that they perform per year and their success rates when assisting a patient in a VBAC. You should also request a list of all OBs that may cover for your doctor and their level of experience with the VBAC. You should also know your rights regarding the VBAC and use your powers as a consumer and patient to change policies regarding the VBAC in your community. For more information regarding the VBAC, please visit our website at www.vbacelpaso.com. This completes our lecture for today. Thank you very much for your attention.